Jeremy, when you mentioned how to find more organs for lung transplant, the one political thing you didn't touch is move to a Spanish model of opting. Everyone is in, you have to opt out, whereas we have the more liberal model. You have to opt in to be in. Have you got anything on that?
No, you're right. At the moment, testing. Okay, thank you. At the moment, it's very much consent-based, so when there is a potential organ donor, even if they've written on their driver's license that they want to be an organ donor, the consent comes to the family or the next of kin. So you're correct, that's an issue. Every jurisdiction is different. So I was talking about international solutions. Nationally, that would be a potential solution, but it's very political, and I don't think that anyone in government has an appetite for such a discussion at the moment. But I think moving forward, it's a very important thing to explore.
Just got a question for Jeremy as well. So after you discussed the morbidity and mortality associated with transplantation with patients that have been referred to you, what proportion decide not to proceed down that path?
I would say, I don't have numbers, but I would say very few. So it's probably more the COPD patient that is unlikely to, apart from delving into those that are hypercapnic with pulmonary hypertension, for example, won't have a survival benefit. Almost everyone else will still say yep, because the alternative is worse.
Jeremy, in terms of retransplantation death rates or decline rates, if you correct for their prior clad, or in a roundabout sort of way, I'm asking if their prior clad is a predictor of their future demise, or if it's a very important predictor.
Do you mean the clad as being a predictor of the
next transplant demise?
Well,
whether their clad on this transplant's a good predictor.
I'm not sure what you're comparing, because everyone that's being retransplanted essentially has clad. So we're not doing it for really any other indication. Some very few patients might have recurrence of the initial disease, but the numbers are pretty small.
All right, we're referring perhaps to the renal transplant model of progressive decline, where you can almost look at someone's rate after their first couple of years with the old transplant drugs to say that, oh, this person's losing 10% of the creatinine annually. Their retransplant tend to do the same thing. Do you have?
We certainly use lung function to predict where to look at where they are and also their trajectory, but it's quite amazing. We do find people that drop precipitously and then stabilise, and others that have been stable, whether it be infection or something else that occurs, there's a significant decline. So we're seeing, it's very hard to say, look at the trajectory as being an FVC decline over, or FEV1 decline over 5 years, and that's what's to be expected beyond, because it's not. We do see quite a variety. And of course, our interventions affect that as well. But we don't have great long-term prognostic data based on what they've done so far.
Oh, but do you have a feel then?
We have a feel.
You think it's probably not the case then?
Yeah, the reality is, again, every group is different. We see our patients very frequently. We have generally about a 6-week interval between reviews. And the major part of that is symptom and also lung function. So in terms of predicting prognosis, it's very much how you are, and we use that rather than how you've been. In terms of retransplantation, we haven't done enough in Perth to really look at this. There are registry studies that have looked at all the risk factors for retransplantation, and a lot of them are similar to what they are the first time around, but with a lower baseline.
Okay.
If I haven't answered your question, come and grab me at lunch.
Okay. Yeah.
Sebastian. This is for Jason. There are some anecdotal reports on doxycycline in ILD. Do you have any thoughts about it?
I think that there is a bit of evidence base around doxycycline and also the macrolide antibiotics in the non-IPF field. So I think some of the more inflammatory interstitial lung diseases have some emerging evidence base I'm not aware of much positive evidence for chronic antibiotic therapy in IPF specifically with any antifibrotic properties.
Gary. They're all great presentations. I've got two questions for David. The first is, I've always been told by experts that morphine needs to reach the brain, but the Magnuson meta-analysis you showed had a comparison between inhaled and systemic, and the data looked identical. So the first question is view on direct-to-lung mu agonists. And the second one, in the world of the mouse, the nuclei that control breathlessness are very discretely localized and they can be genetically ablated. So I'm wondering, has there been any work on brain stimulation or regional ablation of perception of breathlessness as a late-stage palliation for breathlessness?
Great. Two important questions. So in terms of nebulized versus systemic morphine, there's one study which was in people with lungs affected by mustard gas where the response skewed the entire meta-analysis. And if you take that out, then you lose all signal that nebulized opioids have a beneficial effect. Having said that, those studies have not been standardized by the way, by the nebulizers essentially, and there's an interesting group in Poland at the moment who are using dosimetrically administered opioids that will stick in the large airways rather than go into the small airways or get lost in the nasal cavity. They've actually had really very positive responses from relatively small numbers of patients. But our group at the REPAT until Friday was looking at the issue of peripheral versus central receptors in vivo. So we've randomized people to methyl naltrexone, naltrexone and placebo on the treadmill. Those data are due by the end of January. We've finished recruitment and all of the data collection. That really will distinguish at a systemic level on endogenous opioids effects on peripheral versus central opioids. And I'm not sure I'd like to put my last $5 on where that will come down. So that work is underway. In terms of ablation or deep brain therapies, I'm not aware of anything in humans. I think the issue in animal models is one that again, we're putting the science in behind practice rather than science leading practice still. And I think knockout models that allow us to understand that better are actually going to be really important in the next 10 years.
Jason, any questions behind me I missed? No. Jason and David, you both touched on a bit of translational research, getting the evidence into practice. You touched on it with the proton pump inhibitors, Jason, what the evidence suggests, what the guidelines say. David's talked about it, and we see it a lot with the opioids, and we struggle with it with the GPs. Would you both like to comment on what you're doing with the proton pump inhibitors, but how do we advance that further to translate it into the evidence into practice?
Yeah, look, I think it's a tricky one. A lot of the current recommendations are not based on an awful lot of evidence. So this is a transition point really between sort of expert group recommendations and sort of poor quality historical evidence, and moving the field forward in a sort of a prospective kind of rigorous way. And we're going to see this with a lot of things in the interstitial lung disease domain. Most of the work still is going on with the sort of targeted therapies for fibrosis, but there is increasing sort of demand and interest in the sort of anti-fibrotic or the non-targeted therapies. And the reflux story, I think, is something that will change significantly in the next year or two, as it will for a number of others. Remember also that reflux data is still established from post hoc analyses of existing data sets. And I think we're going to see more of that evolving over time as we're getting more and more patients on treatment, and hopefully get stronger evidence that, these kind of things are, what we're doing is right or in fact wrong.
Evidence to practice is always difficult, particularly for established practitioners. It's doubly difficult here because you're not starting from a neutral position, but from a negative position. That is, this should not be done, rather than is there something to do. As with all evidence to practice, and I think all of the literature to date points to the fact that we need a multi-pronged approach if we are going to successfully change the practice of existing practitioners. So this will be through changing the criteria, the indication, the registered indication where possible, working with professional groups, and I think the leadership of the American Thoracic Society, the Canadian Thoracic Society, the American College of Physicians, all of whom have statements out on this, will help, but there's a lot of work to do, and I think this is off-patent, off-label use, and that makes it particularly difficult because there aren't the sponsors there to help with that important change program. Despite that, the uptake is changing, and I think we can accelerate that in years to come.